David, that really takes us to the central issue, which is it's the delivery system, stupid, and it's the cost of the delivery system, right?
Yeah.
I mean, it seems that that's the bottom line in all of this. We are improving performance. We're doing a little better on quality, although, as you just pointed out, that's not universally true in certain measures. But what we haven't done is we haven't really bent the trend, or bent the curve of cost escalation. So what do you see as the cause of that, and what do you see as the solution?
The causes are complex. I don't claim to know the answer to the cause. And one, we got introduction of new technologies, we got an aging population, we have market consolidation that's forcing pricing up, even though the cost of the care services isn't really going up, or the inputs aren't going up. So there's a lot of things going on. We got inappropriate utilization of services. There's new high technology tests and interventions, which, may be great for a handful of people, but we do them for millions of people, which drives up cost for everybody. So there's a whole number of dimensions that are driving up the cost. We've all believed in a managed competition model that said if we had health plans competing on cost and quality, they would find a way to drive down cost within the provider networks. So we're not seeing that working terribly well. So, to get there from here, I think we've got to focus, as you said, on the delivery system. It's very tough for employers to do that. A typical employer has got a small human resources, health benefits staff. They can't possibly manage all the hospitals and doctors in a national network or even a California network. So they rely on the health plans to do that. I think the employers have to set a tough standard in their negotiation with the health plans around performance standards of cost and quality. There are a number of innovative things that we think will help. Some of it is on the consumer side. So, for example, can we give the consumer stronger signals about the choices they are making, whether it's choosing a health plan or particularly choosing a hospital, a doctor, or a treatment. So some of our member companies are trying things like reference pricing, saying, okay, you can go anywhere in our network to get a total knee replacement if you have a problem. But if you go to any of these hospitals that on average are charging more than $30,000 a year, you're going to pay the difference above that $30,000. So we're going to give you a very strong incentive to choose one of these 50 plus hospitals that are managing their costs in an affordable way. Another one of our companies is doing a similar approach with imaging and colonoscopy tests, screening tests. And they're saying to people, we've looked at the price distribution of colonoscopies in California, which, by the way, vary almost tenfold from one place to another, from $500–600 at one place to $8,000 at another. We want you to think about where you're going and realize that the choice you're making is going to drive up costs in the whole system if you choose a not very affordable provider. So we're going to give you an incentive and say, here are all the places in our service area which charge less than $1,500 for a colonoscopy. If you go to one of those, you get the full benefit coverage. If you go to one of those above the $1,500 point, you're going to be paying a big part of that difference. So there's one strategy is to say to the consumer, you bear a part of this cost problem and your choices will make a difference. And if nothing else, it makes the consumer more cost conscious in all the decisions they make. Similarly, with choosing a doctor, if we can begin to get more data on which doctors are both high quality and use resources, that prescribing pen, sensibly with an eye toward affordability. They use generic drugs when they're appropriate instead of brand name drugs. They don't order that extra MRI when it's not really needed for that low back pain. If we can refer patients to those doctors and they have some reason to prefer those doctors, maybe no copay or less of a copay when they go to those doctors, we can have the consumer drive more attention to affordability through the provider experience.
Right.
So that's on the consumer side. I think on the provider side, we've got to think about changing payment. And we've got to give doctors and hospitals a reason to do the right thing and to be judicious in their use of resources. So part of that is bundling payment. So people are paid for cooperating with each other, working across an episode of care instead of each silo trying to get its share of the dollar. Some of it is these accountable care organizations and saying we have a management entity responsible for a budget and for coordinating care to a population. So, in a nutshell, our view is we're not going to control cost with one lever. There's no magic. Maybe some of us thought at some point there was some magic lever we could pull and fix the cost problem. At this point, we're thinking there's a half a dozen tools which have to work in sync to address cost. And those include the consumer's cost sensitivity, the provider's cost sensitivity, that is how we pay, includes some public policy things, includes having better evidence available to help doctors make good decisions. We need to do it with the professional societies. For example, the American College of Cardiology was brave and published a set of appropriateness rules, saying it's appropriate to put a stent in someone's coronary arteries in these situations, it's not appropriate in these. If you're a doctor and you're doing the ones that are not appropriate, somebody should pay attention to that and maybe not even pay you for doing those. So everybody has a responsibility.